Welcome, everyone. Thank you so much for joining us here today. We are going to hold on just a minute while our platform's letting everyone in, but in the meantime, feel free to jump in the chat, say hello. We would love to hear from you. Let us know where you're tuning in from today, and we'll be started shortly here. Welcome, welcome. I love to see our numbers growing. Hi, everyone. Thank you so much for joining us. We will be started in just a minute here. I know our platform's still working on letting everyone in. All right. Oh, awesome. Thank you for sharing where you're all joining us from today. I know that is always so fun for us to see as well. So thank you all for being here. Welcome. Thank you for joining us. I'm going to go ahead and get started. Welcome to today's webinar, Navigating Depression, Early Diagnosis, and Overcoming Barriers. My name is Jackie Zimmerman, and I'm the Public Education Associate at Mental Health America's National Office. I'll be moderating our webinar today. I have just a few notes for you all before we jump into discussion. This webinar is being recorded and will be sent to all registrants in an email within 1 week. We currently do not offer CEUs, but if you would like a certificate of attendance, we have a form that will be sent in that follow-up email where you can request one. I'll also post some links in the chat here shortly, and that will be one of the links that you can request your certificate of attendance. We do have a packed schedule for today, but we might have some time at the end for discussion with the audience. So as we're going today, please feel free to add in any questions or comments that you have in the chat as well. We always welcome our chat participation and highly encourage it. And as many of you know, or this might be new information, today is National Depression Screening Day. A mental health screen is basically a series of questions that are just checking in on your mental health. And Mental Health America offers online, free and confidential screening on our website. I will post the link to that as well. Sometimes it can be really challenging to know, am I just having feelings of sadness or am I experiencing depression? And that's something that we're going to discuss today. And symptoms of mental health conditions can sneak up on you. And taking a screen is one of the quickest and easiest ways to determine if you are experiencing a mental health condition. So thank you for being here. And on this Depression Screening Day, we just want to uplift that and also recognize that it's Mental Illness Awareness Week as well. So today we're going to discuss the importance of that early diagnosis and treatment, while also talking about some of the common barriers that individuals face when seeking care, which leads me to our wonderful speakers for today. I'm so happy to introduce, we have Tam Nian, Brittany Phillips, Pierluigi Mancini, and Polisa Osei Tutu. I will give you a brief background on each of them so you know where your wonderful panelists are coming from. Tam serves as the Director of Ambulatory Care, Mental Health and Addiction Care for Sutter Health. She's an expert in developing, implementing, and running large-scale mental health care projects and programs. She's passionate about identifying needs within communities, creating innovative services, and executing solutions with an entrepreneurial approach. Welcome, Tam. We also today with us have Brittany Phillips. Brittany is a New Orleans, Louisiana native and current resident of Atlanta, Georgia. She graduated from Louisiana State University with a Master's of Health Sciences in Clinical Counseling and has worked in numerous placements within the mental health field, including psychiatric hospitals, community therapy, substance abuse, school systems, and private practice. And she is currently a behavioral therapist at Brightline. Welcome, Brittany. With us today, we also have Pierluigi Mancini. Pierluigi is the president of the Multicultural Development Institute. He is one of the most sought after national and international consultants and speakers about mental health and substance use disorders. His areas of expertise are cultural and linguistic responsiveness, immigrant behavioral health, social and racial justice, health equity, and health disparities. Welcome, Dr. Mancini. And last, we also have with us today Polisa Osei Tutu, who is a licensed clinical social worker with 21 years in the behavioral health field. She's worked in leadership positions, supervised interns, provided direct services, and has used her expertise to advocate for BIPOC communities with regard to health equity in the behavioral health realm. Her current focus is training and clinical supervision, as well as cultural competency in social work and behavioral health as the owner and operator of Sit a While and Heal LLC. Welcome all panelists. I'm so grateful to have each of you with us here today, and excited to get into this discussion on such an important topic this afternoon. And so we'll just jump right into our discussion. We know that depression affects so many people, and if it hasn't affected you personally, most likely you know someone that's been affected by depression. But everyone struggles with stress and sadness and difficulties throughout their lives at different times. And like I mentioned, people might wonder, am I just sad or is something else going on? So when, in your opinion, is the right time for an individual to seek help if they're worried that they might be struggling with depression?
I can get us started, Jackie. First, thank you for having me, and hello, everybody. Thank you for taking time of your day to be here with us today. You know, I think the question deserves a little bit of comment before we get to it, because we were all raised in different households. So our understanding of a mental health issue, of sadness, depression, it varies. Now, overall, I think it's never too early to ask for help. If you feel something is wrong, then you need clarification, depending on how much you are familiar or comfortable talking about mental illness or mental health issues. And the biggest difference that I would put out there is it's perfectly normal to be sad. You know, we have these differences of opinions as to how do we manage emotions. Emotions are not good or bad. You know, the emotions are emotions. If I feel sad, I'm going to feel sad. I think and sadness is a normal reaction. You know, I lost someone. Things happen that I didn't get what I wanted, and that's perfectly normal. When it starts becoming an issue that affects your everyday life, that it keeps you from enjoying the things that you usually enjoy, when you start giving up on your sports or movies or going out for walks or talking to people, you know, and that starts lasting for a period of about 2 weeks, it's time to really seriously talk to someone about it. Like I said before, it's never too early if you think that there's something going on to seek help or to ask questions. But I think when you start seeing that it's affecting your daily life and it's affecting the things that you used to love to do, then you may need to have some professional help to move forward.
And I want to piggyback off of what Pierre Luigi said. It's I agree. It's not one of those questions of it's if you feel different. It's if you ask somebody else, am I depressed? That's not always the best gauge, because their definition of sadness may not be yours. And the reality is some people have higher thresholds for pain, higher thresholds for anger, different emotions. It's just, I don't feel myself. And sometimes it's helpful to talk to someone who doesn't know you, to use different screening tools to then say, yeah, it's worth talking to somebody else. It really is never too early, because sometimes what happens is sometimes we wait too late. And then it requires an even deeper intervention that makes it feel even more intense, and then requires more support. So I agree with what Pierre Luigi said.
Hi, everyone. Thanks for joining our conversation today. I'm really excited to be here with everyone and the panelists to have this conversation. And I completely agree with what's already been shared, and just wanted to add that I think another piece to consider is mental health stigma, to highlight the piece around it's never too early to inquire, right? It's a question that we're asking. And it's helpful to get some validation from someone else who may know us and others who may not know us as well, in terms of gauging where we are in terms of how we're feeling. And there is variation of mental health stigma across different cultures, different ethnicities, different races, gender. And so sometimes as an individual, you may think, oh, this is just the normal challenges of living that we all have. And I just need to, work harder. I just need to suck it up. And sometimes that's the case. So we all have our own level of coping strategies. So I just wanted to add another piece is when you notice that your own coping strategies and managing the day-to-day challenges of your activities and living isn't working as well as it used to in managing your moods or your ups and downs, that might be a signal that perhaps what you have to manage is no longer working for the challenges or stressors that you're experiencing in this moment. So that can be a great signal to you to say, do I need a little more support for this particular situation? But to just highlight around the mental health stigma is that's why it's never really too early, because for some of us, we may think this is something I need to manage on my own. And why can't I? Other people are doing it. So is there something wrong with me? And those are some generalizations that I'm sharing that can happen to all of us when we're a little more vulnerable, right? Whether we're not getting enough sleep, we're just not getting the same kind of nutrition or diet that we did, or work has been more challenging, or school has been more challenging, and so we're a little more vulnerable. And when we tend to have a little more negative thoughts about ourselves and tend to put the sort of agency, the responsibility of how we're feeling and how we're responding on ourselves, when it could be a number of external factors that are impacting that. So just to say, just to highlight, it's never too early, and there are some clinical criteria around when we know this is a really helpful time, to the point of 2 weeks. You're experiencing a number of symptoms related to sleep, your appetite, level of interest. If you're beginning to have suicidal ideation or feelings of hopelessness, those are also indications that it's a good time to perhaps follow up with your primary care provider and get some additional feedback and an evaluation and treatment recommendations.
Yeah, so much great information has been shared. I kind of want to highlight the passive symptoms that may come about when it comes to depression that can sometimes be overlooked. Those are also things that might differ depending on the culture, because in certain cultures, some emotions are more acceptable to display than others. So some of the passive symptoms, such as the eating changes, social changes, I've also seen with some of my clients, more irritability, heightened irritability, or reckless behaviors. A lot of times suicidality can be passive when it comes with depression. So instead of saying, I really don't want to do life, or I don't want to be here, sometimes you'll see people do behaviors where they just don't care what happens to them, which can also indicate depression or passive suicidality. But yeah, I just wanted to piggyback off of that there are so many symptoms that can be passive that we sometimes don't link to depression. That might be a big indicator that you need to talk to a professional.
Absolutely. Thank you all.
I wanted to add one more thing as my fellow panelists were talking, is that also why early screening sometimes is really helpful is because it could be an indicator about underlying medical conditions, such as low vitamin D, hypo or hyperthyroidism, anemia. So sometimes those early screenings, your primary care physician may want to run blood work, and then you learn those things in addition to sometimes depression and other behavioral health issues. So these are all helpful things to know.
Absolutely, and thank you for bringing that up. I think that screens can be so helpful too in this technology-driven world where it really is so easily accessible, but often we get misinformation. And so you go to Google and you type in symptoms and you get a list of the 50 most intense things that could be happening in your body right now. And then where do you go? And how do you trust it? And you know, a lot of these screens, they give you that concrete information of what might be happening. Again, it's not a clinical diagnosis, but then it gives you a better idea of where to go next and some next steps for you. So thank you all for your thoughtfulness on that. Our next question, we know that seeking help is so important, and the earlier that individuals can receive care and help, the better for their outcomes. But often it can be challenging for a variety of reasons. What are some of the most common barriers that you've seen individuals struggle with when trying to receive treatment?
Well, the populations that I represent and that I serve is usually Hispanic, Latino communities, and lately immigrant communities at large. And the issues are pretty much two columns. There is culture and there is language. Now, we have all of the other issues that many Americans are facing in this country. We have a tremendous shortage of clinicians. We have access issues. We have discrimination. We have all of that. But in the community I represent is primarily language and culture. And we just don't have an infrastructure in this country to be able to provide mental health and substance use disorder services to individuals with limited English proficiency. Now, the shortage of clinicians for the general population is large and is true. And for clinicians that speak other languages, it's even larger. So when I look at that, those are the two primary issues besides all of the other barriers that we're all facing.
With the different clients that I've served in terms of African Americans, Afro-Latinos, clients of African descent, religion plays a big role. I'm not crazy plays a big role. Family, generational trauma. I made it through, so why can't you? Also to, I think, media, this kind of idea of it's not a big deal. So there's been, and access, insurance. There's certain insurances that only cover a certain amount of medical coverage. So some insurances will say we will pay for 20 visits. If it's substance abuse, it might cover more. If somebody needs hospitalization, it won't cover anything at all. In terms of long-term treatment, you have to, if it's schizophrenia, it'll cover this. If it's maybe just generalized anxiety. So there's so many things that prevent people from accessing care, whether it's financial, socioeconomic, and generally speaking, people feel like from those particular communities, it has to be extreme before they seek help or access the help, or they might go to their religious leaders for support and try to pray through it. And I do believe that spiritual religious support is very helpful, very essential. But what happens is it might stop there, and the other part gets doesn't get supported, and that tends to be a big issue.
Yeah, to piggyback off of that, A large portion of my population that I've served has also been African American, and just being an African American woman myself, stigma plays a very large role in the reason why a lot of people in my own community does not seek mental health. I know that there's the idea of the strong Black woman that's often placed on African American women, having to be the hub of your family system, not just being the hub there, but not really being allowed or having the space to feel emotions, or even not just feel them, but to deal with them. Another thing that I've seen in minority communities and communities with people of color is a lot of times those resources are just not in certain communities when it comes to therapy. A lot of times you have to travel outside of your city or outside of your community in order to access these resources. And when you're in a community that already frowns upon the display of emotions and already frowns upon talking about mental health and normalizing that, a lot of times people are not going to want to travel outside of their community to go and seek those. So one thing that I've really loved in the transition from being in-person private practice, I've transitioned to being an online therapist, and I found that a lot of people are a lot more open in their community to be able to do therapy from within their own household. It doesn't feel as taboo. And it also just, it creates a way for those services to be more accessible, so that people are not having to find the finances or the transportation to get to their therapist, because it does just create another barrier for that treatment.
And, I think the other panelists have already mentioned this, but I sort of think about it from, individual level barriers, some of the stigma, cultural, linguistic pieces, and then there are systemic, I would say, barriers. And the panelists have mentioned that around insurance reimbursement, location challenges around being able to access the care conveniently and at a time that works for the different communities that we serve. And I would just wanted to add around the systemic challenges is that, even as a healthcare provider myself, as a psychologist, I find it so extremely challenging to navigate our healthcare system, to actually get linkage and coordination to the services that I need or my family needs, whether those are my kids or my mother, right? And that, I think, is a real challenge, is that when someone is struggling with a mental health condition, depression and or anxiety, other symptoms, it is the system that we have currently does not help facilitate individuals getting connected to care, that there's so many different numbers we have to call, so many different folks we have to tell our stories to. And I do think health systems in general are getting better at that, recognize that, are being innovative, using technology, meeting people where they're at, partnering with communities to improve access. And I think we can continue to do more around removing those systemic barriers to accessing care.
Absolutely. Thank you all. Any last thoughts on that question? Wonderful. Well, a lot of really great points brought up by each and every one of you. And I know a few of you have, well, if not all of you, have already touched on this a little bit. But if we can even expand more on it, you brought up this struggle specifically that a lot of our BIPOC communities face, those increased challenges to finding and receiving treatment. And even we see the disproportionate rates go into actually being diagnosed once you find the treatment, and the underdiagnosis and misdiagnosis of BIPOC individuals. And so what disparities do you see our BIPOC communities facing most often in mental health diagnosis and treatment? And how can we work to properly advocate for their care?
I think misdiagnosis is one of the biggest problems that we have. And, the sad part is that a lot of it is fixable. Again, for the communities that I represent, that I work with, one of the focusing again on the linguistic barrier, there's two avenues that many organizations take, because I truly believe most organizations want to do the right thing. They just don't know what that is, and sometimes they do things that ends up causing more harm. So two things that people utilize is a language line or an interpreter. Now, language lines for immigrant communities is very impersonal. You don't know who you're talking to. It's a voice on a phone or a box. And we don't know what kind of training that person has had in mental health or substance use disorder language. And we see a lot of problems with that as one of the biggest reasons for misdiagnosing. Same thing with interpreters. You know, very few medical interpreter curriculums include behavioral health language. And that's problematic, because if the interpreter does not understand what it is that the clients that are looking for help are expressing or how they're expressing it, then they're going to tell the clinician information that is not correct. That's going to lead to a diagnosis that doesn't make sense, or even worse, an involuntary commitment that is going to cause additional trauma. So those are the biggest ones that I'm looking when I look at the community. So that's why the effort has to be to build this bilingual, bicultural workforce. Now, I want to make sure you understand, I did not say Latino workforce, right? Bilingual, bicultural. When I had my clinic, I had 5 clinicians who were not Latinas, but they were bilingual, bicultural. They lived in Central America, they lived in other countries, and they understood the language, they understood the culture, and our clients loved them, right? At the same vein, I had Latino individuals who were not bilingual, bicultural, and they caused a lot of damage. So we have to make sure that we focus on the language and the culture, not necessarily labeling that the person has to be from a certain group. And the last one I would say is even interpreters in even harder to find services for communities like refugees. Those communities are very tight-knit. So if an interpreter comes out of the community, chances are they know you. So then that creates another barrier, because how much am I going to tell this neighbor about my problems? Because, you know, things happen in those small communities, and I don't want my information to get out there. So very real and very serious barriers that we have when it comes to disparities.
I think one of the big challenges when it comes to diagnosing is competing factions. We do get paid by the insurance companies, and insurance companies operate from the medical model. And most of us, all the panelists, I'm sure, are strengths-based. We see every person who comes into our offices, or whomever we meet, as individuals. Insurance companies, no offense to them, or maybe offense, don't. They see diagnosis. And so because of that, we are constantly, there's this ethical dilemma that we as clinicians go through. And what we end up doing is fighting with ourselves about how we sometimes diagnose people, but then still respect who they are as individuals. And I always tell my supervisees that they have to remember that diagnoses follow people. Insurance companies have this giant database that they put all our information in. And so even if you leave Allstate and you go to Geico, Geico already knows your information once you give them your social security number. So they are supposed to be very clear on what diagnosis they give an individual, to be very thoughtful and very methodical with it. An individual can come to me crying, hysterical, but that does not mean that in that moment, that is necessarily who they are, and therefore that is going to be their diagnosis. They are worthy of me saying, I'm going to have them come back a few more times, and I have to get to know them before I solidify this diagnosis for them. I can give them a preliminary diagnosis and update it for the insurance company. Maybe I have to fight them I may potentially get rejected and not get paid for 2 sessions. I might have to possibly eat it, but it's worth it for me. And that is where that cultural competency, humility comes in, because it is worth it. Because I have seen individuals come to me with diagnoses of bipolar disorder, and I say, no, that is chronic PTSD. That is not bipolar disorder. That is not schizophrenia. And it has been clients of color. And I'm very, very mindful of that, especially when it comes to children, when it comes to African-American males, when it comes to Latinx immigrants who have been through hell and back, that they've gotten these diagnoses. And I say, they've been through hell and back. Of course, that's who they were when they came to your office that day. So I think that's another piece of it, is us as clinicians really pausing and not just looking at the DSM and going 1, 2, 3, 4, check, and then putting down a diagnosis.
Yeah, to piggyback off of the competency piece, I do think that it's extremely important as clinicians. We're not supposed to be biased, but as human beings, we all have different biases that we should not let come into our job. And that's a lot of times how these misdiagnoses happen, because we think that because a person is from a certain culture, this must be one of the diagnoses that most often fits people of that culture. And that's such a disservice to the client. Just piggybacking off of what Polisa said, I think that it's really important that you don't make assumptions. You get to know who the client is, especially their background, because even geography and where they live can play a role in, how different things present and how they respond to different triggers. So I think that's really, really important as well. But yeah, I also think as well too, that just piggybacking off of the part of not going through the DSM and just checking off different things, in different cultures, different symptoms present completely different. So a lot of times, when we see anger, specifically with my African-American male clients, anger is once again an acceptable emotion. It's a masculine emotion. So a lot of times anger can be used to cover so many other things. It may not be truly anger. It may be hidden sadness. It may be depression. It may be something else. So it's really important that we continue to try to get to know that client, allow them to tell you who they are instead of you assuming that or looking at their culture and letting those stereotypes take over.
In addition to the pieces that my fellow panelists have already shared, I just wanted to add a couple of other things. One around sort of the cultural linguistic language piece is, yes, right, we need so much more in terms of the tools and being translated in the languages that really feel our country, and that we are starting to do that. And I think the piece around the language is that, to Brittany's point earlier, how mental health is talked about or described, or the worst news for mental health, vary across cultures. And so we also want to be very thoughtful about the language and how it's expressed in different cultures and in different community groups, and to be able to translate that in a standardized tool so that it's really meeting the needs of the communities we're serving. And that really can best be done, I think. One way to be able to do that is through ongoing research and being able to conduct, working with the people to better identify what the language might be, and doing some trials around that and iterative examples of what some of those tools might look like that would be more appropriate for the populations that each of us serve. And beyond that, I would say also the existing mental health screening tools that we have today, super helpful, and we need to screen, and the norms for them are based on the majority population. The norms are not based on, we're not formed on various communities of color. We're comparing norms to give us a sense of, here's where is it this patient or individual lies compared to the sort of majority population. And so we want to keep that in mind when we're working with different communities, especially communities of color and communities of different ethnicities and races, to be mindful as clinicians that that's a tool, and really it's a comprehensive evaluation, right? Clinical interview in which we're using all of these data points to really help support us in identifying what might getting an assessment or clinical formulation of what might this individual be struggling with. Is there a category in which it generally falls that we all can share and communicate with each other to be able to better support this individual. The other piece is, I would say, the other side of this coin is some individuals don't want a mental health diagnosis in their chart. And so they are less reluctant to, one, report the symptoms to their provider, and or even may say to the provider, I don't want you to put that diagnosis in my chart. So that can also then impact the course of care that the individual might receive. And so I think that those are some situations in which, as clinicians, we really want to be thoughtful and mindful how to best meet the individual where they are. That makes a lot of sense. There's a lot of concerns about mental health data being in electronic health records, and how that information is shared amongst care providers and other care teams and systems and healthcare systems. And so I think education and training are the folks that we work with around that, and how that's being used and why can be really helpful to really get them to be able to then fully understand their treatment options, and then of course supporting them with the treatment choices that they make.
And I also want to add that, America still has a lot of things that it has to reconcile with regards to things that it has done to marginalized communities. And so, yes, people of color have not been properly represented in studies for clinical trials. So things like medications, we don't know their true effectiveness with all of the BIPOC communities. Homosexuality was identified in the DSM-3 as a disorder. Histrionic personality disorder was identified as like kind of a gender specific diagnosis. So, when we talk about African Americans and why they feel the way they do about being parts of studies, we have the Tuskegee experiment. Hillary Clinton, just when she was Secretary of State, just apologized to the country of Ecuador for what this country did to sterilizing women in Ecuador illegally. So these are all factors that we still have to reconcile within this country that plays a role in why people who really do want help are still so hesitant. So all of these things, when doctors do go to speak with people of color about their mental health and why they're hesitant to seek treatment, they do have to keep those things in the back of their minds. And why people now are also being more vocal about wanting to work with providers that look like them. Like, this is also where it's coming from. They're like, hey, maybe I can trust somebody that looks more like me. And it's nothing against someone who doesn't. It's just, I don't want to have to explain if I say this type of slang or talk about my cultural meal or dinner, like, I don't want to have to go into the explanation of it. So I think that's also where we are now too. And it is really nice to see. I used to joke that, foreigners, my family's from Ghana, it wasn't a thing for us to become social workers. I was supposed to become a pediatrician. We were pharmacists and everything else. So to hear my nieces and all of them saying like, oh, I'm going to become a social worker and things like that, it really does make a difference that clinicians are starting to represent the communities we're serving.
Absolutely. Thank you for that. And you brought us perfectly into our next segment, which we talked about some of these challenges, and I did hear already the talk of solutions and what we can start to do. And I know on these webinars in particular, we have a lot of counselors, therapists, physicians that join us for these. So speaking to those individuals on the call right now and other mental health professionals, how can we work to close the gap on disparities that BIPOC communities face when it comes to treatment and diagnosis?
I believe that we begin with ourselves. You know, we use words that sometimes we truly don't know the meaning of when we talk about cultural humility, health disparities, equity, disparities, unequal treatment, all of those things. And we need to begin with ourselves. We all have our own story. We all were raised in environments that gave us messages that were not true or were not right. So we have to do our own demystifying, our own cleansing before we can help anyone else. If we don't begin with ourselves, there's going to be implicit bias within us that is always going to be a barrier to us to be able to truly serve someone and try to be as impartial as we can. After we do that, we have to work with the organizations that we work with or with the system, like Dr. Nguyen said. We have to be able to speak up. You know, when I talk to people, I tell them, we're going to get to a point where you find your voice. Many of the people who are listening to us, you know, I can see in the chat, they're all excited, you know, they want to take action. So you find your voice. That's the first step. But the next step is you have to learn how to use your voice, because there will be instances where you will be the only person in a meeting, in a session, in a board, in a committee who actually has the right information. And if you hear that misguided information is being put out there, it's our obligation. It's not even a responsibility. It's our obligation to raise our hand and speak up, because we may be the only people that can then start breaking those barriers. Education in all communities, beginning as early as we can. You know, 3, 4, 5-year-olds. We need to flood these young minds with education about the natural order of emotions, and that we don't have to run from them. We don't have to stuff them. We don't have to not say anything if we're hurting. And when we talk about immigrant and communities with limited English proficiency, we need the proper education. Not everyone follows the westernized definition of mental illness and the westernized treatment for mental illness. So we have to approach individuals at the levels that they are. We have to listen to how they tell us their symptoms. In Latino communities, symptomology often is pain in my back or pain in my neck. And what they're trying to tell you is that they're emotionally hurting, that it is not just necessarily a physical symptom. So we begin with ourselves, then we work within our communities, within our agencies, and then we, you know, speak up whenever we have to bring the right information to those groups.
I couldn't agree more. And to add to that piece around working on ourselves, I think we all will do that. And even when we do that, we may make an error, mistake in our working relationship with the patients or their clients. And so demonstrating humility and just sort of vulnerability and saying, I noticed that I made a mistake there. I and apologizing for it, and then really showing by example, how do we rectify or resolve that, right? And really listening and learning from the people that we care for, that it's really a bi-directional relationship and a learning one, and that we can always benefit from learning. That's one of my biggest values, is I can always learn in most situations, in all situations, and recognizing when I'm being a little bit big-headed, right? And thinking I know it all, and for the most part, most of us don't know it all, right? There's always so much more that we can learn. And so just highlighting that piece around it's the reality is we all have stereotype biases that we've learned through our social learnings, our interactions with others in the world, our different experiences. We have some level of awareness to them. And there are some things where we know how that shows up in our interactions. Other times we don't know how that shows up in interactions. And so in the moments in which we can engage in correcting that, it can be really helpful to then just put us all on the same page about we're all here to try to support one another, lift one another up. I may have a set of skills that can be helpful to you in this moment. And then there are so many things that you're teaching me as well. And so there's that piece around just sort of our collective voices. You know, I'm from the Bay Area, a big basketball and Warriors fan. So really believe in the strength in numbers mantra around putting our collective voices together. And then really at a policy level, thinking about how do we implement policies to really support some of the operational things that we need to do? And at an education level for our social workers or our psychologists or psychiatrists or marriage and family therapists, how do we incorporate training around supporting communities of color? Are those on board exams? Questions around that. Are those on board exams or licensure exams? Because we know that when those questions are on there, professors are teaching about it and students are interested in it. So those are just other ways to kind of think about how we can make larger scale impact.
And I think to piggyback on both of my fellow panelists, every individual that I meet in my role is a unique human being worthy of support as just that. No assumptions to be made. And whomever they are, it's for them to tell me. And I learn as much from them as they hopefully learn from me. And the biggest thing is that when you sometimes make too much assumptions about people, it then causes issues. Just as we are talking about difficulties with the BIPOC community in terms of clients, there was a recent study that came out that BIPOC social workers are not passing the social work exam at the same rate as their white counterparts. So this just kind of speaks to a bigger issue, systemic issue. So I just want to highlight that there is a bigger issue that we all are having to explore now. And so hopefully this discussion also is making everybody reflect on what are we doing as a nation, as a world, to just kind of be more mindful of the beauty that is this kaleidoscope, kaleidoscope of a world, to care for all of us as human beings, and that there's a bravery for anybody who walks through a hospital, a outpatient clinic, anything, seeking help when they don't feel like themselves.
Yeah, I think my fellow panelists have made so many great points. I really love the point about, checking our own biases and making sure that, we're looking at the client as an individual. I think while we have a duty to that client, we also have a duty to stand up when it comes to the organizations that we work for and our fellow clinicians. As clinicians, we do a lot of consulting with one another, especially if you're in a particular organization together. And I think it's really important during those times of consultation to check microaggressions. You can do things professionally, but definitely check microaggressions and make sure that you're open to learning within your organization. I've worked within a few organizations that not maliciously, but out of just lack of information or resources, or maybe that not being offered as something for clinicians to look into at the organization. They just didn't have a lot of cultural competency. So I think that it's very important that we advocate for that in our different organizations so that we're making sure that we're all giving the best level of care to the clients that we serve. I guess another important point would be as well, that as clinicians, we make sure that I understand that we have a standard for when it comes to what we do for our clients. And at the same time, I think that it's important that we make sure our services are as accessible as possible. So there are a lot of clinicians that may be working in just in-person services or private practice in-person services. There's going to be certain clients that can't come into you. There's going to be certain clients that financially may be supporting a large family, or maybe working long hours. So it's very important that we're looking at sliding scales, or we're looking at different things to make mental health more accessible for all individuals and not just a certain population.
Absolutely. Thank you all for that rich discussion. I know we're getting close to the end of our hour, but I'm going to sneak one last question in for you all. I said, we have a lot of health professionals on this call, but we have all humans on this call, and all people that feel and hurt and struggle. And there might be people on this call right now who are struggling and are feeling those symptoms of depression or anxiety or other mental health conditions. And for those who haven't sought care yet, but are struggling at this moment, what first steps would you suggest they take to recovery?
Well, the first thing I would tell individuals is you're not alone. We hide our feelings, and you may be sitting next to someone that's having a worse day than you are. So you're not alone, and there is help available. So those are the two main messages. Now, since July 16, we have a new tool. So if you haven't heard of the new crisis hotline, 988 is the answer to the mistreatment that we had so many times when we called 911 for a mental health issue. 988, you don't have to be in crisis. You can have questions. You'll talk directly to mental health professionals that can guide you on what to do. Now, if you have a crisis, or if you are feeling suicidal, they can also help you with that. So that is the fastest way to get to talk to someone, is by using that line. In the first couple of months, I think they decreased the wait time from 2 minutes and 30 seconds to about 40 seconds or less. Just imagine waiting 2.5 minutes to talk to someone when you're in crisis, right? The other thing I would say is don't be afraid to ask for help. You know, it takes courage, and you are a brave person. So if you are looking to reach out to someone, do it. Don't wait. Don't question it. It never hurts to ask questions, and you may be avoiding some very difficult period in your time by asking for help earlier. So I would say those things. If you're suffering, or if you know someone that's suffering, don't wait. Reach out. It should be as simple as asking someone if you broke your arm. It should be that simple. So don't be afraid to do it. And if it's yourself, call 988 or tell someone else. There is help available.
To piggyback off of that, I'm going to try to be short and sweet because we only got a few more minutes. But one thing I would say is I think that sometimes going one-on-one with a clinician or a professional can be pretty intimidating for some clients, especially people in the BIPOC community. I would say that that doesn't have to be your direct line if you're dealing with something and it feels more intimidating. Group therapy is something that I've seen work for a lot of people, especially if you go to group therapy with a lot of other people that may look like you, that may be dealing with some of the same things. It creates that idea of people that you can relate to. It also creates that feeling of, I'm not alone and I have these people here as a support system. And then maybe you can graduate from something like a group therapy or some type of community resource to that one-on-one specific therapy with a clinician, to where you can kind of target in on just the things that you have going on. But I think that group therapy is something that could really help you get comfortable with talking about what's going on with you. It can give you that encouragement that you need from other individuals. And it can just kind of get the ball rolling before you get real specific on what you have going on one-on-one.
Wonderful. Thank you so much. Any last comments? I know that we're right up at the hour, but I want to make sure any last thoughts or feelings
Yes.
from our speakers. Go ahead.
Yes, Jackie, before we go, I meant to also say, if you have recovered from anxiety, depression, please tell people, share, don't be afraid to share. We need to let people know that help works, that counseling, medication, the combination, that there is help and it works. We do get better, we do recover, and we need to share those good news to allow others to take that step.
Absolutely. Thank you all. Well, thank you to our panelists. I appreciate each of you so much for being here. I can tell from our chat they did as well. Just a reminder to everyone joining us, this is recorded. It will be sent out to you as well as some of those resources that we had discussed earlier. So thank you all. Have a wonderful rest of your week. And remember that there is help available, there is screening available, and on this Depression Screening Day, sharing that, either taking it yourself if you're struggling or sharing that with someone if you notice signs that they might be struggling as well. Thank you.
Thanks, Jackie. Thanks, fellow panelists. You guys are amazing.
Thanks,
Nice
everyone.
meeting everybody.
Thank
Take
you.
care.